So a very good evening to everyone. A warm welcome to this ISCCM educational webinar. As intensivists, we stand at the front line of a battle that is evolving silently but very aggressively. A rise of MDROs, the multi-drug resistant organisms in our ICU. What was just a microbiological concern has now become a clinical emergency, complicating even the most routine infections and limiting our therapeutic choices. So in today's webinar, we'll be focusing on two crucial pillars. One is the recent diagnostic techniques, and other is the clinical significance of resistance patterns in MDROs, and then the real-world challenges which we face regarding these MDROs in our day-to-day practice. So for the first talk, I would like to invite Dr. Soumya Sridharan. She works as an ID consultant in Apollo, Chennai, and she is going to talk about the recent diagnostic techniques. She will walk us through these tools which she has, which is reshaping early detection in day-to-day practice. Thank you, Dr. Soumya, for joining us. Over to you.
Thank you, Dr. Mona Lisa. I exactly have 15 minutes, so I'm just going to start right away with my presentation. Hope my slides are visible. So I'm going to talk to you all about the recent advances. Actually, nothing exactly recent or very recent that we have in our country. These tests have been there for quite some time. I'm going to address as to how to position these tests in clinical decision making and clarify confusions, as in distinguish between the noise and the music, so which we should give credence to. So I'm just setting the context with this AMR thing, which is looming and which is a big threat to the entire mankind. I would say about 7 lakh people die of drug-resistant infections every year, and this trend is actually on the rise. So what we have on our armamentarium is the new rapid diagnostic tests. So these are new kids on the block that have been doing quite well for the past few years in terms of reducing the time to diagnosis and decision making. So as you know, as in critical care physicians, time to effective antibiotic therapy in a patient who's septic is crucial, and any delay would cost the survival of the patient. And RDTs, not only rapid diagnostics, not only help in escalation, they also help equally in de-escalation of any toxic antibiotics that you would want to avoid for your patients. So RDTs are definitely the need of the hour. If you see the traditional growth-based techniques, as in your blood cultures, which we've been having, the good old ones, the blood culture, you have to wait for the organism to grow and then plate it, and from that you're going to do your broth microdilution or your diffusion for your susceptibility testing, which is going to take quite a while, around 3 to 5 days at the earliest. So this as a long turnaround time and significant hands-on, as in the experience of a microbiology or a lab technologist, is going to be crucial. Coming to your molecular-based techniques that are there, we have quite a few in the last few years, and these actually are faster, much faster, and they are more automated, so give you accurate results in a shorter period. Just to name a few, we have Expert MTB, we have the line probe assays, the respiratory panel, the pneumonia panel, the CMV viral load, but I'm not touching on all of these because they are not going to help you in your susceptibility testing. So what I'm going to deeply dive upon is your Expert CARBA-R, which is a PCR-based one, your BCID panel, and your syndromic panel, just for an overview, because all of these are not exactly associated with MDROs. So I'm just going to touch upon 3 important ones, which is your MALDI-TOF, Expert CARBA, and BCID for the next few minutes. So blood culture is the only thing that I would, upon for any patient who's septic. Please send adequate cultures, volume, and the number of sets, and do not compromise on the blood culture volume and the sets that you're sending, because the diagnostic yield is very good. But when you wait for your blood culture, what else can you do? You've ordered a blood culture on a septic patient, and when there is a flag on that, when there's a growth, the lab alerts the concerned nurse in charge that there is something growing, and you take it out of the bacteria alert mission. Most of the labs these days have the bacteria alert, and then based on that you do a smear, and then you say a preliminary report, as in a gram negative or a gram positive has flagged. But the advantage of having a rapid diagnostic, as in a MALDI-TOF, helps you to give the ID the same day, reliably. Most of the times you get the MALDI-TOF on the same day, which helps you to decide on further molecular testing, whether you're going to go with your BCID or your CARBA-R. So this actually helps in terms of escalation and de-escalation quite quickly, and you can do it on the same day of your culture flag rather than waiting it out. So if you're ordering for a blood culture, traditionally these are inoculated into bottles, goes on to the bacteria alert system, and then from there, when there's a flag, it is removed, and then it's plated, and then you subculture. If there are 2 or 3 bacteria, they have to subculture it. And then you do your traditional AST methods like your broth microdilution and your disc diffusion, and then you finally release a report. Whereas whenever there's a flag, if you're going to take out the bottle and do a rapid susceptibility testing, as in if you have your MALDI-TOF or an expert CARBA or a BCID, it's going to quicken the antibiotic decision making on the same day, because RDTs have definitely proven that the mortality risk is lower, and we have good evidence to say that it helps with antimicrobial stewardship, and the effective number to treat is quite good, which is 20, and the effective therapy, time to therapy actually is reduced by 5 hours, and the length of stay is reduced by around 2.5 days. So now these days, wherever applicable, molecular diagnosis for bloodstream infection are the need for the hour and the standard of care for any good ICUs. So this is what I was trying to say, that it takes around 3 days minimum for you to get your antimicrobial susceptibility reports. Whereas if you have a rapid ID as a nucleic acid based or a PCR based one, or FISH these days, it reduces and you get the result in a maximum of half an hour to 8 hours, depending on the test that you're going to order. So MALDI gives you only the ID. So if it's going to flag and you're going to do a smear and you find a GNB, then it's easier if you get a MALDI. If you have access to MALDI, you can put it on MALDI and it would give you an ID reasonably well on the same day itself. So it's just that the system has to be updated to include all of the latest bugs. So even Candida auris has been added on to MALDI, and you will be able to MALDI your organism on the same day. And if you have access to blood culture ID panels, actually what we have in our hospital is the blood culture ID panel. We do not have the Verigene system. We have the film array. And this blood culture ID gives you the ID of the bacteria and also the resistance markers. So you will get the ID and the resistance profiling, genotypic resistance profiling on the same day within a few hours, a maximum of 4 hours turnaround time. And expert CARBA is also a useful tool. Again, it has a very rapid turnaround time. So if you have access to MALDI and the CARBA-R, probably if you're not looking at your Pseudomonas or your Acinetto, these are non-fermenter organisms which do not typically rely on your enzymatic methods of resistance. What I mean to say is your non-fermenters can have other methods of resistance, as an abhorrent channel or efflux pumps, which may not be picked up on all of these genotypic tests, especially your CARBA-R. So if your MALDI says Pseudomonas, then I wouldn't actually go with a CARBA-R for these patients. Instead, better to order a BCID where you get the ID and your sensitivity. Again, this also gives you only the enzymatic methods of resistance, genotypic resistance, but at least you would save money on ordering your MALDI and expert CARBA instead of a BCID panel, because BCIDs are quite costly compared to these two put together. The other platforms that can be typically potentially upcoming are the FISH panels and accelerated diagnostics, but we do not have access to all of these. So I'm just going to rush through those topics. So MALDI, I told you the turnaround time is less than 15 minutes, and it actually, we have studies to say that it is a very important tool when it comes to antimicrobial stewardship interventions. The blood culture ID, it gives you all your typical gram negatives. It also touches upon your Candida and your gram positive. So it is a whole lot of plethora of organisms that you get to see on a BCID. So these are all the targets that are identified. Quite a majority of your bugs in the ICU would be identified. And of course, your ESBLs, carbapinamases, the traditional 5 carbapinamases, and also your MEK and BAN-B genes. All these are also identified in case of MRSA or a VRE. So this is actually very good in terms of gram-positive or gram-negative bacterial infections that you see, whereas your MALD is slightly better for a gram-negative identification as compared to gram-positive, but it does not give you the resistance testing. And an expert CARBA is only typically used for an Enterobacteriaceae group because you cannot rely on it for the other bacteria. So this is a study that we've published from our center, where we found that there was 90 to 99% concordance with the BCID and your traditional cultures in terms of identification of the bacteria and yeast, and around 96% concordance compared to your phenotypic and your genotypic testing. That is your routine drug susceptibility testing that you get, and your genetic profiling, genotypic profiling that you get on a BCID. So it was quite reliable, more than 95%. So it helps you in deciding your polymyxin-based therapy. And this is another study from our center for the CARBA-R that we use. Here, around 169 gram-negative isolates from 160 patients were analyzed. And based on this report, around 10% had an escalation of antibiotics to a colistin-based therapy, and around 30% had a de-escalation, which is quite significant in terms of avoiding toxicities and your unnecessary antibiotic overuse of antibiotics that could lead to antimicrobial resistance. Overall, we identified that OXA48 was the predominant genotypic resistance that we saw, and and it was the positivity rate of this test was around 35% on all the samples, as in whatever was used. So the sensitivity was very good. The specificity was equally good, around more than 90%. And the median time to the report was around 30 hours. That is less than 1 day, around 1.5 days in terms of reporting. But reporting as in your action taken or time taken to act on the report, that's still quite high. But this has actually significantly reduced because this study was published quite some time before, but now we've tailored the place of this drug and the de-escalation, this test and the de-escalation happens quite faster. So when you suspect sepsis in a patient in the ICU, draw blood cultures and start empiric antibiotics. If there is a flag, direct MILD helps if you're going to look at your Enterobacteriaceae or a gram-negative. And ordering a CARBA along with that is going to be helpful. So if there is a flag, look at the possibility of having an Enterobacteriaceae gram-negative sepsis versus your hospital bugs, as in a VAP or a CLABSI, where you cannot pinpoint that it is not going to be Acinetobacter pseudomonas, because in our ICUs, Acinetobacter is the top pathogen when it comes to VAP. So you have to go according to your antibiogram and whatever is common for your syndrome. So once it is positive and you identify, you're going to escalate or de-escalate as appropriate. But if it's going to be a non-Enterobacteriaceae group, a BCID in these situations would be helpful, because CARBA is not reliable and you would not get a reliable answer. So you can just directly go with your BCID instead of a CARBA in these situations, CARBA with a MALD possibly. And coming to your fish technique, which is not here in India as of yet, I think so, at least in our center, we've not used this. This also helps. These are again from positive blood cultures, and your accelerate pheno system reduces the time to pathogen identification by 28 hours. And for the susceptibility testing, it's almost by 41 hours. So definitely this also is helpful. Again, this is on a positive blood culture only, like the tests which I told you sometime before. That is your MALD, your CARBA, your BCID, all of these, even a fish works only on a positive blood culture. This nuclear magnetic resonance, that is the T2 system that we have, it is for the T2 bacteria and T2 candida. Here, this is just done on the whole blood. So directly you can draw it and then you can send it, and this detects around 5 common bacterial species. It's again not available here. For bloodstream infections, it identifies staph, your enterococcus, pseudomonas, E. coli, and clef, which are most of the top pathogens in any of the ICUs. And your T2 candida, again, this also identifies the 5 most common candida species, be it your albicans. It again reduces your turnaround time. It's around only 5 hours directly from a whole blood. So it identifies these species, which are almost most of the bugs that we see. I don't think this identifies Auris. Still, we would have to go with your MALDI. And definitely in terms of candidemia, if you have access to your beta-D-glucan, this is not a resistance marker, but at least it would help you. It's a biomarker from your that is shed from the fungal cell wall. So it is actually helpful for its negative predictive value. And if you have access to a beta-D-glucan, so you could order it along with your blood cultures whenever you suspect invasive candida. And this would help you in terms of de-escalation. If a BDG is negative and your blood culture is negative, you could reliably discontinue antifungal therapy. So BDG is indirectly useful for your MDRO treatment choices, and hence I've included that also as one of the important tests for today. But what are the barriers in implementing all of these RDTs? There is lack of education or expertise, as in you need training. Most of these are automated, but you will have to train your personnel to handle the equipments. And if there are suboptimal patient care pathways, as in a physician orders it but doesn't know what to do with it, if it is a coagulase negative stuff, so do I have to intervene or not? And if sometimes they do not know what tests are validated on what, so you need to have patient care pathways put in place before you implement these tests on a daily basis. The other major barrier that we face is the high pricing and your quality assurance. So you will have to look into your lab expertise along with the price when you order these tests. Clinician education is very important, and you will have to know which is your colonizer and your contaminant. For instance, if you order a pneumonia panel and there are a lot of bugs that would be picked up, 2 or 3. So you do not know if it is a colonizer or a contaminant, whereas your culture, if it grows and it fits into your system.
Even we don't have much time, please, why? Because there are...
Sure.
Sorry.
So this is my last penultimate slide, actually.
Yeah.
So yeah, I would just wind up shortly. So this repeats your resources also. So it comes at the time of cost. So I'm just skipping this case which I had in want of time. So I'm coming to the last slide, which are my take-home points, which are crucial. MALDI, if you have it, order it along with an expert carba, especially in a gram-negative sepsis which you suspect. In places where Pseudomonas or your Acinetto non-fermenters cannot be ruled out, directly order a BCID because you would get at least a direct ID on that. And clinical expertise is very important to make sense of what tests are going to show you. And all of these off-label sepsis panel, which are done on direct blood, are not approved or standardized, and kindly refrain from using these. The only one that is available on a whole blood is Candida T2 system, and none of the others have been validated for sepsis. Thank you so much for your time.
Thank you, Dr. Soumya. I think this was great. And all these rapid diagnostic tests, which you have told that how they actually significantly reduce the turnaround time, and they also help in organism identification. So next we'll be moving to a very important topic, which is very important for all the exam goers. And I'm sure Dr. Bharat Jigyasi is going to do full justice to the topic. It is about clinical significance of the resistance patterns which we see every day. So Dr. Bharat Jigyasi is Director of Critical Care in Kokilaben Hospital. He has been our General Secretary in the year 2024-25. So he's going to talk about this very important topic, and we have 150 plus attendees. So over to you, Dr. Bharat.
Yeah, thank you, Dr. Mona and Dr. Jacob and ICCM leadership and all the seniors over here. So my topic of deliberation today is clinical implication of resistant patterns of MDROs. And as you all know, the reality of resistance is like when I think of the bacteria being resistant, I think of the Ravana. The moment we cut the one head is the new one which emerges. So the moment we think we have dealt with it and we have conquered the resistance, is a new technique or the new mechanism which comes in and proves us strong. So this is again a simple case scenario what we deal in the ICU in and out, and it's the resistant patterns which dictate these days the treatment and the prognosis even before the cultures comes in. And we'll talk on the resistant mechanisms, culture report intervention, and maybe I'll touch a bit about the targeted therapies because it's about the clinical implications, and we have to see how the clinically we can correlate what treatment needs to be given. So when you talk of the MDROs, we all know it doesn't reside in the microbiology lab and in the textbooks anymore because we ICU are the epicenter of it, and we almost see 1.27 million annual deaths, and 67% of the carbapenem resistance and Klebsiella and other strains. Acinetobacter is supposed to be the intrinsic resistant, and the three major MDRO threats what we look into is, and more majorly we look of the escape is the one thing, so which consists of six species, and two are the gram positive, four are the gram negative, and most commonly seen in the critically ill patient and immunocompromised hosts. So, understanding the mechanism of resistance, I will directly come to it because we are currently running short of the time. So there's something called as intrinsic resistance and acquired resistance. So intrinsic resistance is something which bacteria are hardwired in a way right from the birth, and it's very difficult to defeat that because they have that natural defense mechanism in play, and it's very important to know that. And acquired resistance is what is a real battle what we've been fighting against. They acquire it as they grow through the different mutations or when they come across the resistant organisms, and we as a empirical use of the misuse of the antibiotics, I would rather say, are been fueling this fire. So the forms of resistance, it could be the natural intrinsic one and acquired as we have spoken about in various formats. So when we talk of the intrinsic resistance, why is it important? Because they are born with it. So eventually these organisms are not going to be sensitive to those antibiotics, and we need to be very aware of it, because if we start with the empirical antibiotic in some of the strain which is intrinsic resistant, we lost the battle already before even the resistant mechanism comes in play. So if you look at all this, you look at the Pseudomonas laughing at first and second generation of cephalosporin, then ampicillin is big no for the Klebsiella. And if you look into the important strains, we can take a picture of this sheet. This is a quick ICU cheat sheet which shows the natural resistance. It's like if you look at the Pseudomonas, ampicillin is resistant, first and second generation cephalosporin resistant, even the tetracycline resistant. So when you talk of the Acinetobacter carbapenem resistant, Enterococcus cephalosporin can't be acting, and ampicillin we cannot be using in case of the Klebsiella. And when we talk of the acquired resistant mechanisms, as Dr. Soumya also touched the topic, so there are enzymatic inactivation, target modification, and permeability changes is what we have been looking into. So when you talk of the enzymatic activation, there's the beta-lactamases, aminoglycosides, and chloramphenicol, and target modification. As we go through, we look into the different other mechanisms as well, like permeability changes inclusive of pore channels, efflux, cell membrane, which is mostly seen in the non-lactose fermenters. So even when the dish is laid off, within few hours we can see whether it's pink or pale, and it's very important to recognize it because it helps us differentiating between the lactose fermenters and the non-lactose fermenters. So within few hours you can actually make out without really knowing the what organism, what type it is. Why is it important? Because the lactose fermenters are usually enterobacterials, what we look into, and the mechanism of resistance they have is the enzymatic one, like ESBL, MC, and CRE is rising, and those are mostly of the gut flora origin. And we look into the non-lactose fermenters, these are the high intrinsic resistance, Pseudomonas and Acinetobacter, and they acquire resistance very fast, and we have to really go with the higher antibiotics in those cases. So it could appear either pink or pale yellow, and if it's pink, then you have the bacterialis. It's pale yellow, then it could be the Pseudomonas, Acinetobacter, and Sternotrophomonas maltophilia. So why is it important? As I told you, if it's lactose fermenters, then it's mostly common the enzymatic mechanism. So maybe the BL-BLI combos or the carbapenems will play a good role. They'll be the good empirical strategy over there. But when it's non-lactose fermenters, maybe if they have a high intrinsic resistance, we need to know the bug common in your ICU. If it's Acinetobacter, you couldn't be using carbapenem. With Pseudomonas, you can't be using tetracycline, and then maybe you might end up using colistin or some other thing. So when we talk of the Ambler classification of beta-lactamase, this is not just ABC, this is ABC of microbiology. We need to know it very closely, and it tells us what mechanism it is so that you can choose your weapon very wisely. So when it comes to Amber class A, it's mostly the ESBL, and Amber class B is what we are worried about. It is the metallo-beta-lactamases. It gives us NDM, WIMP, and IMP, and Amber class B is BIMP, MC. And Amber class D is what we look into in the oxalinase, that is OXA A, OXA 48, and OXA 43. So if you look at this chart very clearly, so when it's ESBL, when we have to look into it, maybe it's sensitive to the cefoxitin, and also the clavulanic and tazobactam are very much sensitive. This strain would be acting, will be sensitive to these two. When it comes to MC, it would be the cefoxitin resistant and the clavulanic and tazobactam resistant. So why am I talking about the MC and MA is the reason being, if you look into the overall different patterns into this. So ESBL producers and MC producers, for the ESBL theoretically you might say BLBLI will not work in certain cases, but they might be helpful in the may work in the low inoculum. And if you look at this chart, they BLBLI in case of the ESBL might work in mild to moderate cases, but of course not in the severe cases. Might be good enough in the immunocompetent and when the infection is from the urine or SSTI and intra-abdominal infection, but not in the severe infection, the bloodstream infection, or when the club is the organism, and when the eucast MIC is more than 16 to piperacillin tazobactam. So this is why it's very important to identify those strain. And as we come into the ABC or the EMPHA classification, what we look into is the class A is mostly the ESBL, class B is NDM, WIMP, and IMP, and class C is MC, and class D is OXA, mostly in club and oxygenobacter, what we look into, and they have the variable carbapenem resistance depending on what organism we come across. So this is the stairway to doom. We start with the beta lactamases, then carbapenemases, ESBL, MCs, KPCs, OXAs, and MBLs, and we really need to know what antibiotic acts. So now this is a different set of the resistant mechanisms, and we have the antibiotics. So if you look into this, aztreonam and avibactam would be very good for the KPC and NDM and OXO48 and maybe the sternotophomonas. But if you look into the capidarocolol and ceftizidime avibactam might not act on the NDM, as well as it is not supposed to be acting on the carbapenem resistant Acinetobacter as well. If you look into the fosfomycin, it's might work in the KPC, NDM, but of course it will not work on the Acinetobacter and sternotophomonas. And polymyxin, again, we all know it's always an intermediate. It might or might not work, but tigecycline, of course, will not work on the Pseudomonas aeruginosa. So this is why it's very important to know what trait it is, and so that we exactly know which empirical antibiotic we need to start with. And the treatment options when carbapenem result is available could be again this: when we have the metallo-beta lactamases, we can use a prolonged infusion of ceftazidime, avibactam, and aztreonam. I'll skip this slide. So what is important with the aztreonam and NDM is the complex relationship, because as we can see, aztreonam is resistant to hydrolysis by NDM. So alone it should be very much effective, but there's a catch in it. Most of the NDM also carry other beta lactamases. So it's not in one mechanism which is acting. They have the co-resistance mechanisms as well, like ESBLs and MC. And these are the enzymes which can again destroy the aztreonam and making it ineffective. So someone might say it's NDM and aztreonam is very much resistant to the hydrolysis, but there are other mechanisms also coming in play. And this is why we mostly combine aztreonam with avibactam in those cases. And there's a difference between MDM and E. coli versus Klebsiella. We all know Klebsiella has multiple co-resistant mechanisms, but E. coli have few resistant mechanisms. But there's something called as PBP, that is penicillin binding proteins, so which are essential for the bacterial cell wall synthesis and target site synthesis of beta-lactam antibiotics. So what E. coli does is they reduce the affinity by PBP3 mutations, and they have been associated with reduced susceptibility. This is why the ceftazidime, avibactam plus aztreonam efficacy is not as good as in E. coli as in the Klebsiella, as the PB3 mechanism is more common in the E. coli and less in the Klebsiella. So what do we do? Whenever we are detecting a PB3 alteration, how do we detect it? It could be detected with the whole genome or targeted PCR. Or maybe we can do an MIC interpretation. If the aztreonam MIC is more than 5 microgram per ml, despite protection, we have the reduced efficacy of the combination. So whenever we have the NDM, always identify the organism. It's E. coli versus Klebsiella. Check the resistant markers NDM, and then interpret with the, if you don't have the mechanism, identify the PBP3 resistant mechanism, then interpret with the aztreonam MIC. If the MIC is less than 4, then likely this drug is going to be effective. It's more than 4, then maybe you have to go to the other options. So detecting resistant mechanisms is not that easy. It's like a spoiler in the blockbuster movies. They will tell you the plot before even the picture has been released, and we can twist it as we want it. So if we run across the detecting mechanisms, we would know exactly what we are coming across even before the organism has been grown. And this is what it was touched by the Soumya as well. So some other organism which is very common is Acinetobacter baumannii is become a persistent threat in the ICU, and it has the OXA20 is the predominant carbapenemase, and polymyxin remains the backbone, and combination with rifampicin in this shows the synergy. And the sulbactam component of ampicillin sulbactam has intrinsic activity, and the higher doses of sulbactam has shown to work well in along with the combination. Then second is Stenotrophomonas multifila. It intrinsically resistant to the carbapenem, resistant to aminoglycoside as well. The first line therapy for this would be the trimethoprim sulfamethoxazole and remains a good gold standard. And alternative options could be the leofloxacin or maybe the minocycline. So what do we do in case of stepwise algorithm approach? So we identify whether it's ESBL or MC. Then we can see whether it's a severe infection or the low grade infection. It's a UTI, maybe then we can try BL-BLI combination, being very with optimized dose and being very cautious about the fact it might turn out to be resistant. In the severe infection, we have to go straight away with the carbapenem. If it's CRE and there's a KPC, OXA40 or NDM, then of course, if it's a KPC producer, then we can go to the ceftazidime avibactam monotherapy. It's an OXA48, then maybe CZA might be effective, and NDM astronome might work in. But if you see the astronome MIC is more than 4 microgram per ml despite protection, then suspect and clinical failure along with the combination therapy, and we might choose to the different set of the antibiotics in those cases. So again, novel antibiotics, we all know this, ceftazidime avibactam, meropenem, vabrobactam, and imipenem relibactam, eravacycline, and plasmomycin. So we need to know the what spectrum of the resistant patterns these all works in, and these are the clinical perks. So when we have a severe infection and we suspect these kind of the resistant patterns, we can start these antibiotics as the empirical therapy. Now just a touch about the gram-positive resistant patterns, because the talk is about the MDRO, so it needs to cover everything, but I spoke mostly about the gram-negative, and I'll just touch upon the gram-positive resistance. I have just 3 minutes of left. So consists of... Sir, sorry?
Less than 3 minutes, I said.
Yeah, less than 3 minutes. I'll finish it fast. So the MRSA, VRE, and resistant pneumococci is what we look into, and they have the different MACA genes, and Van A and Van B genes is what we look into. And if we look the clinical compatible illness, the culture has grown gram-positive, we look into the coagulase positive or not, and look for oxacillin and cefoxitin resistant pattern. If it's resistant, then it's turned out to be MRSA. And the MRSA preferred therapy, we all know the vancomycin, but we need to be worried about the MIC creep. I can't explain in detail because of want of time. Pneumonia is linezolid. Then we have to look into the VRE management challenges. So the genes which are resistant are the Van A and Van B. So Van A gene is high level resistant, and Van B gene is variable resistant, altered peptoglycan precursor. So detection matters because we would exactly know what we are dealing with and what will be the prognosis of our patient. So MRSA treatment versus VRE treatment, let's skip this. So we have a visa and H visa. So these are the types of bacteria which have the laboratory may report susceptible despite clinical feature, but neither higher vancomycin troughs or alternative agents. And in the linezolid resistant VRE, if there's a 23S RNA or CFR gene mutations, then we have the limited treatment options may require high dose of daptomycin or combination therapy. So the treatment challenges, we all know the diagnostic gap, we have the therapeutic limitation resistance evaluation. So identify the bug, predict the resistance, choose your empirical antibiotic as per the resistance pattern, and learn to read the culture report so that we have the valid results. Thank you very much, grateful for your attention and time. I hope I finished in time as well. Thank you.
Thank you so much, Dr. Bharat. I think it was really useful for everyone who attended this. I wanted to take so many snapshots, and there was a question also where a panelist was asking me when can we get this link and when will it be uploaded in YouTube. So I'm sure they liked it. So we'll be moving to the panel discussion. Over to you, Dr. Jacob.
Thank you once again, Dr. Bharat and Dr. Soumya, because attendees have gone up to 170. So not much of a time waste. As Dr. Ashit said, we will go to the next interesting section, which is the panel discussion. Managing MDROs, the real world challenges. That's something which all of us should be knowing it. And I think the panel, the moderator and the panelists, everyone knows that what is their contribution to the field of infection. It's my honor to invite Dr. Ashit Hegde, who is from PD Indija Hospital, Mumbai, as a moderator. Along with him, the great panelist, Subhash Sodhi sir, an extremely iconic figure in the field of infectious disease from Amri Hospital. Dr. Ajit Kumar, Asra Whitefield from Bangalore, and he's also the Secretary of Indian College, and Dr. Neeraj Tyagi from Kingaram Hospital, Delhi. So over to you, Dr. Ashit, because we don't want to waste time.
Can you see my slides? Can you see my
No, sir,
slides?
no, sir.
No, sir, not yet, sir.
No.
Sorry.
Dr. Soumya and Dr. Bharat, you can also stay back for the panel, and there's some questions in the Q&A section.
Sorry, really sorry. What's going on? I don't know. 1 minute.
No problem. I think after the panel discussion, if the time permits, if delegates wants, maybe we can discuss Dr. Soumya's case in the end, if everyone stays.
Yes,
Sure.
that'll be great.
Sorry, I was trying to share my slides.
No problem, sir. Chirag will help you. Chirag, please help, sir.
I got it. No, I got it now. Can you see my screen now?
Yes, sir.
Yes, sir. Yeah.
Fine. So I'll start.
Just
now.
put slideshow.
Yeah, I'll put on slides. So I'm sorry. I just changed my. Fine. So we're going to have this panel discussion, and I would. You can see my slides, no? Yeah.
Yes.
So I would recommend anybody to have questions. I think Jacob, with any questions, I can't see the Q&A, so please let me know. Okay.
Yes.
Fine.
Yes, sir. We'll let you know, sir.
Some cases which will essentially try and put into practice what we learned from the previous two talks. And if you have questions for the previous speakers, also please put them in the Q&A or chat, and we can address them either now or after the end of this panel discussion. So I won't waste too much time now. And so this is the first case. This is a 62-year-old female. She's a diabetic. She's had history of recurrent UTIs. She was admitted for UTI several, and the last admission was 1.5 months ago, for which she had received meropenem. Now again, she's admitted with fever, loin pain, hypotension, needing vasopressors. Of course, in any patient with septic and uric, you were going to rule out obstruction, emphysematous pyelonephritis. But my question is, of course, what would be the empiric choice of antibiotics in this sick patient who has been exposed to meropenem in the recent past? So if I'll begin with Neeraj, I'll ask all the three panelists for their opinion. I hope they disagree so they can have some discussion. So Neeraj, first to you.
Thank you, sir. I mean, it's been something that we probably struggle day in and day out. Although the dictum says that if it has been meropenem or any antibiotic that has been used in previous 1 month, we should avoid it. But when you go about the history, recurrent infections, this patient has definitely a possibility of carbapenem-resistant infection. And primarily, when we talk about carbapenem-resistant infection, the thing that comes is Enterobacteriaceae. So probably what we need to do is cover for the possibility of CRE in this patient. And definitely the choice of therapy will depend a lot on about what kind of imaging we get on kidneys. But if strictly sticking to antibiotics, nowadays what we are probably doing is going more towards susceptibility testing and then looking at these things. And if I go by my pattern, one of the choices could be, if they're susceptible, of course, it can be.
No, I'm saying empiric. See, Neeraj, at the moment.
Yeah, empiric. I mean, I'm talking about the antimicrobiome of my hospital. So my empiric will depend a bit on that, because this patient has been probably following up with us. So could be aminoglycosides if they have been proven susceptible in previous admissions. Of course, one can also use high dose of fluorophenols. If this patient is simply suffering with cystitis, nitrofurantoin, despite being on vasopressors, is a very good choice. But in new word, of course, if you want to cover other things, then ceftazidime, avibactam, and then combining it with estrione is what we are looking at as one form of therapy. Another form of therapy could be something which is primarily based on colistin, and you add something else with that. So this will be probably the thing based on.
What would you give? What would you give?
Sorry?
What would you give in your hospital in this patient?
In my hospital for this patient, probably I'll go with ceftazidime, avibactam, and estrione.
Fine,
And
thanks.
probably give one of the aminoglycosides with that to cover for.
Aminoglycosides a little later because our new aminoglycosides come, but so that's
Yeah.
so like I said, so cystitis generally will not come with shock. So I think nitrofurantoin is out of question because cystitis is an OPD thing. So you would give ceftazidime, avibactam. What about you, Ajit? What is your choice in this patient?
Yeah.
You're suspecting CRE because the patient received carbapenems.
Yeah. So in our practice, what we do is obviously we send the culture. Obviously, this patient who has received meropenem in the last 1.5 months ago. So I would still what we do in our practice is that once the initial culture is flags off, then we do the CAR-bar testing. The CAR-bar testing is showing OXA positivity or plus NDM positivity. We go for ceftazidime, avibactam. Maybe in this patient, depending on how bad is the shock, maybe it's around 2 to 5 ml of noradrenaline. It's a sort of subjective disease. I understand.
Severe shock. So we are talking about difficult cases. So
yeah,
refractory shock. You can't afford to be wrong.
Yeah, then I'll be going for ceftazidime, avibactam plus estrione. I'll be empirically starting this patient. There's a risk stands very high risk of resistance at ES.
Yeah, we're going to deal with patients who are pretty sick. So obviously, because you can't afford to be wrong. And before you get your testing back, so both Neeraj and Ajit say they would use ceftazidime avibactam, which, like I said, this is just a discussion. Each one, there's no right or wrong answers. Each one has their opinion, and each one has its logic beyond that answer. Subhash, what is your opinion? What would you use in this patient?
Chit, I would definitely agree that carba-resistant Enterobacteriaceae, E. coli, and Klebsiella would be number one. But we should never forget enterococci, somebody who has received meropenems and probably other gram-negative coverage. Do think enterococci is sometimes the second most common cause of severe urinary tract infection. So I would cover enterococci till I get the culture results with teicoplanin, and have a quick look, depending upon the creatinine. Have a quick look at the urine to see if they have a lot of yeasts in it. And I think, again, patient
Diabetic also is there, you're right. So, of course.
think of fungus. So think of CRE, think of enterococci, and think of fungus.
No, the reason I brought this case up because, Bharat made that point later about PB3 inserts causing resistance in E. coli, in which situations aztreonam and ceftazidime avibactam might not work.
It's too early. It's too early, Ashit. And I think the epidemiology still has not gone to that extent that we need to cover empirically PVP3. Yes.
I said in a sick patient who's hypotensive, whether you would afford to risk a resistance or
still Oxa and NDM, I would say, still are the predominant.
No, I understand. But the point is that if there is NDM, ideally you're supposed to, like Bharat put in his talk, and I'm sure Dr. Sridharan also, is she around? What are your views? Would you use? My point is that it's a very sick patient who's on vasopressor. Of course, you're going to wait for blood culture, genetic testing, etc. But empirically, would you cover ceftazidime avibactam, or given that E. coli in India PB3 is becoming a problem, would you switch to a polymyxin-based combination and a fosfomycin-based combination? Otherwise, because fosfomycin also covers the enterococci, which Subhash is rightly worried about. So,
I think still I would go cover for NDM until I get the results, and definitely Oxa. So ceftaz, aztreonam.
And most people seem to think ceftazidime avibactam would probably be all three, in fact, probably
with
at the moment. So basically, the lesson is that somebody's been exposed to carbapenems. Obviously, you need to think about what is not been covered by carbapenems. So as Subhash covered, certainly CRE, but also probably in a diabetic, you think about, not in a diabetic, enterococcus certainly, and also maybe you need to think about Candida, especially because also a diabetic. So Candida nephritis also is possibility. So all three you need to rule out. Fine. So so this is the same thing. So the treating physician, like you all had said, has having aztreonam to cover for CRE. Now the patient has undergone stenting. Of course, that's the most important thing, as you all know, in patients with the pyelonephritis and shock. Unless you rule out an obstruction and treat the obstruction, sometimes they're not going to get better. But so she's marginally better, because quite often after relief of the obstruction, they get better, even if they're not on the right antibiotics. And the blood culture grows E. coli, and the BCID panel is showing CT, XM, and NDM. So again, back to the panel, Ajit, what would you continue the same, or would you do testing for PBB3, or just continue with what is going on, or you de-escalate? What would you do?
Yeah. So the BCID panel takes CTXM, that is just showing that ESBL is there, and NDM is also there, this is expected to cover. So if here obviously the patient is in severe shock. Obviously, we all do the routine precaution. We will see that there is no other reason which could have caused the shock in this patient. Obviously, we all look for other causes, and there is no need to discuss that. Then if the shock is still worsening, I will think about empirically adding which can cover an NDM, other organs, like empirically adding other option, maybe like a colistin, adding colistin to this, or maybe maybe fosfomycin would be an option, empirically adding fosfomycin to this. And I know there is a new medicine which has come, plasmomycin, in India, but I never used that, so I can't depend. I cannot comment about that. And cefiderocol also supposed to be effective against NDM, but in this situation, I will look for all other possibilities which might be worsening the shock apart from the resistance. Then I would think about adding colistin in this case. That'll be my take on this.
You can't use polymyxin, you're right. So you have to use, if you want to use for UTI, you have to use colistin. You can't use polymyxin because
Yeah, we'll be using I'll be thinking of adding colistin rather than obviously polymyxin cannot be used.
That's what you're right. So you can't use polymyxin. What about you, Neeraj? Say you agree with him?
I think I started with ceftazidime, avibactam, aztreonam, and one of the new aminoglycosides. So plasmomycin is one of those new aminoglycosides that I was talking about. The advantages covers for MRS as well. Doesn't cover VRE, but yeah, MRS in this patient is far more likely. The way we are having our antimicrogram. So probably now this patient is just having CTXM and NDM. The source control has been done. So this is the time for me, probably I'll try to, because for E. coli, we do not need more than one antibiotic. So probably I'll continue with plain plasmomycin. It's going to cover both CTXM as well as NDM in this patient. It has been approved and we have been using it.
What about you, Subhash? What are your views? We'll talk about plasmomycin in a while.
Yeah, once we have grown E. coli and it is an NDM, CTXM is always associated with NDM. And if a patient is on ceftazidime and aztreonam, we need to do a synergy test now. Now the patient has grown an E. coli, so whether the synergy test to ceftazidime and aztreonam is positive or not. If it was Klebsiella, in India it is said that you don't need to do synergy, it is almost 100% synergy positive. But for E. coli, only 60 to 70% are synergy positive. So I think that will be the first step that I would ask my microbiology lab. Now that you have grown something, do a synergy for ceftaz and aztreonam. And the second thing, Ashit, that I think I would like to emphasize to our audience is, the dosing of ceftazidime aztreonam. In critical care, we decide on the first dose depending upon the creatinine we have done on the admission. Now, over hours, because of resuscitation and right antibiotic, the creatinine comes down. And the next creatinine is usually done the next day. But, the dose probably need to increase by the evening. So that is the second important thing is, overdosing is okay because these are pretty safe antibiotics, but underdosing in a septic shock is big problem. So probably repeating a creatinine in another 10-12 hours and then adjusting the dose in the evening. Otherwise, so that will be the second point. And third would be source control, as Neeraj mentioned. So I would do a synergy test, do a quick creatinine again, and adjust the dose. That will be my second.
Of course, the resident should.
So I would like to see the blood culture report as well. So basically, the BCID panel that is detecting, the two genes are detected, and conceptually speaking means the cumulative resistance. So this is that depends on there are at least 4 different mechanisms are there for for the carbon resistance. So we are looking for we are detected one gene for the New Delhi beta-lactam resistance, one gene we are able to see. But so that means most important message, my understanding is obviously with all these gene testing what we are doing, we have to see what the blood culture report showing actually, the sensitivity of the blood culture report. That also we would like to see.
I think Ajit, several points have been. Yeah, Subhash, what did you want to say?
Just one, if the synergy is positive, then we are okay. The question is, if the synergy is negative in an E. coli, which is showing the CTXM and NDM, then what to do? That is where Bharat has mentioned the PBP3 mutation. That is most likely is the mechanism of resistance to E. coli. And in the present day, with availability of antibiotics, even with dose adjusted with creatinine, plasmomycin will be a choice. But there is an NEJM article on a monotherapy with plasmomycin in complicated UTI, including acute pyelonephritis. We don't use aminoglycoside as a monotherapy, but given these kind of situations where we have a PBP3 mutation, but probably if there is an NDM with PBP3, whether would like to go monotherapy with plazo, or you'd like to add ceftazidime, aztreonam, I don't know. What would you do, Ashit?
We'll talk here. So I think several important points have been made. So I'll just summarize them before we go to the next question. One, of course, that if we have, like he said, if it is an E. coli and there's an NDM, it's in our country, for E. coli, we need to do for synergy testing, because if synergy is positive, it might be safe to continue Piptaz, Avi, and Astronam. But if synergy negative, you need to think of other options, whether it is fosfomycin, colistin, or colistin fosfomycin, or plasmomycin. We'll discuss. That is one thing that's important. Second is the pharmacokinetics and the pharmacokinetics. You need to make sure you don't reduce the dose just because of renal dysfunction. And third, probably you need to infuse your, of course, it's important for the residents to know that you need to infuse your ceftazidime and avibactam together through a Y connection. They should be infused simultaneously over 2 hours. And important point Ajit made is that, of course, you can't always, you can escalate based on BCID panels, but BCID panels don't cover every possible mechanism of resistance. So to de-escalate, it is probably safer to wait for your phenotypic reports to come, because your phenotypic may show something which is not there on the BCID. So maybe it is safer not to de-escalate in a sick patient until you get phenotypic results, because sometimes those resistant genes may not be on the panel. But to escalation, certainly a BCID panel will help you in a sick patient. But as Ajit said, you also always need to then wait for the phenotypic sensitivity, which of course unfortunately takes 1 day more, takes at least later than the BCID. Therefore, after that, you might again have to fine tune your antibody depending on the phenotypic sensitivity. So the next question, of course, we talked about, I mean, the 2 new antibiotics that have been promoted in our country, cefepime N-metazobactam and plasmomycin, they've both been sort of proposed or used for UTIs. So first we'll talk about the cefepime N-metazobactam. Has anybody used that? Any views on that for severe UTI?
Yeah, this is a carbapenem sparer, in the sense that the study which has been done with cefi and it has been FDA approved for complicated UTI and hospital acquired pneumonia and VAP. It covers ESBL very well. In fact, it is better than piperacillin tazobactam. There is no head-to-head study with cefepime N-metazo and meropenem. As you know, in Merino trial, meropenem was better than piptase, but there is no head-to-head between ceftaz and this N-metazo. So this is a good anti-ESBL and maybe a carbapenem sparer.
So essentially, so like you said, so this patient may already been exposed to carbapenem, probably no role. It could probably have been used
I don't think this would work.
instead of meropenem. So somewhere you're suspecting not been exposed to carbapenems in the past, so it's probably just a little better than your BLBLIs for UTI, somewhere between the usual BLBLIs and, or maybe equivalent to a carbapenem, but certainly not better than a carbapenem. So I think it definitely
the industry is pushing it as carba sparer. The only study is head-to-head with piptase. There is no study with carbapenem.
So we are not sure yet. Somewhere between piptaz and meropenem, probably.
Exactly.
So
somebody who's not in shock. If somebody is in shock with ESBL, carbapenem. Not in shock, you might get away with this.
So that's a lesson for the students.
So cefepime and metazobactam, it is not effective against NDM. It can be effective against certain OXA.
That's they claim, but there's
but not much. You can't use it. No, once you get sensitivity, we can use it.
Not actively in OXA 48, so it's it's a absolute low in Indian situations where most of the ELBS they have poor production of OXA 48. Probably against OXA 24 it does work a bit, but that's it.
But by and large, most of the E. colis are not pure OXAs. By and large, they also have NDM. It's very unlikely they'll have a pure OXA. So empirically, I don't think you can use it. Once you get culture back, sensitivity back, showing sensitivity, maybe you can switch down if the patient is getting better. But empirically, probably in a sick patient, you probably can't use it because it almost never is a pure OXA, even in E. coli. So
the only trial is non-inferiority against piperacillin tazobactam, and probably that's how it's best seen. So even looking at it as a carbapenem sparer in Indian situation is probably, as of now, is an overstatement.
Not in sick patients, like he said, maybe somebody's not really that sick, maybe you might consider it. Where for a UTI which is not that sick, getting better with fluids, maybe you might consider. So it's somewhere between piptazo and it's a little better than the other BLBLs. That's all I would think. Now, about plasmomycin, Subhash has raised the point, and even Neeraj just talked about the usage. See, my view on this is that I agree that it works for PBP3 insert, but abroad definitely it works because abroad they don't have NDMs in their E. coli. In India, we have a lot of NDMs. And when there's an NDM, the NDMs co-carry a 16S methyltransferase gene with inactivates aminoglycosides. So unless your phenotypic sensitivity showing that plasmomycin is sensitive, I don't think in our country we can use plasmomycin empirically, because quite often our NDMs in India co-carry this methyltransferase gene, which destroys the aminoglycosides, all even plasmamycin. So I would not, if it is sensitive, definitely you can switch to plasmamycin. But until you get phenotypic sensitivity, especially in NDMs, I don't think you can use plasmamycin empirically. That is what
No, I
my
was coming to that
learning
only.
from the literature, that I can't use plasmamycin empirically. Certainly, once I get the sensitivity back, I might use it as a spare of any of these things, but not empirically. That is my learning of what I have learned because of this co-carriage of the 16S methyltransferase gene, which destroys aminoglycosides. So that's my take on plasmamycin. No empiric therapy, but of course, after you get sensitivity reports, you probably can use it. Any other comments anybody would like to make?
The only way you can use plazo, a little empirical, that if you are growing something like E. coli, which is synergy negative.
No, but you can be NDM. It's still NDM.
It's an NDM, but synergy negative.
No, but it has that's not synergy because
if it is synergy
negative, it can still produce a gene. That gene is separate, no? The methyltransferase gene is completely different from the synergy.
No. What I'm trying to say is then that means my ceftazidime aztreonam is not going to work.
Not going to work. So you have either fosfomycin or.
So we have to add something.
You can add plazo, hopefully.
Not as a monotherapy, probably is the best way to look at it.
And that is where plazo may be added till you get your final culture results.
Or you switch to fosfomycin because it covers enterococcus and this. So that's the other option, of course.
Yeah, the use of pilo, phospho, IDSA guidelines do not recommend phospho so much, but I don't think we have much options. So might be worthwhile looking into that.
So we have already one case has taken time, but Subhash will go try and stay behind for some time, but we'll go to the next case quickly.
Yeah.
So the 67-year-old male admitted with extracerebral COPD and severe hypercapnia. Needed intubation, ventilation, was prescribed piptazone admission. Day 7 in the ICU, breathing difficulty because of severe bronchospasm and all that. Develops a fresh episode of fever, sputum. So obviously developed a fresh VAP and somebody already on piptazone, day 7 in the ICU. So again, I'll start with Subhash this time. We'll go the other way around. So what would be your choice of empiric antibiotics in this patient? Day 7. And
so this patient has developed a VAP, I presume.
Yes.
Right? And in our unit, if I put 1, 2, 3 will be acinetobacter, Klebsiella, and Pseudomonas. We don't have staff coverage. So we don't have MRSA so much. So I need to cover in my unit, which I think is probably not true for PD Hinduja and others, is we need to cover acinetobacter. So I would cover for acinetobacter and Klebsiella in this patient.
So what would you give this patient?
I would give a combination of sulbactam, minocycline, and for Klebsiella, probably I would give ceftazidime, or if this is not exposed to carba, so I would give carba.
No, but you wouldn't give polymyxin for your acinetobacter.
No. Not yet, no, because lung pneumonia as such, the penetration and all, I need to probably high dose sulbactam, minocycline, and see how this patient goes.
So what about you, Neeraj?
Typically in my ICU, when we are talking about day 7, we are looking at a CRA producer. And Acinetobacter, thankfully, is not even 10%. But yeah, I'll agree with Dr. Todi. Is empirical therapy, we need to cover both for fermenter as well as non-fermenter. So probably my choice in this patient would be simply polymyxin and minocycline. But there is one more organism, particularly in this patient I would like to cover. This patient is COPD, has received IV steroid. And day 7, what we have seen typically is the chances of aspergillosis in this subset of patients, the incidence is very high. So there is one organism also I'd like to cover empirically. So maybe
but you're not getting better, you have to think about aspergillosis as well. So
yeah. So this is the same time. So this is what I'll do, and then obviously send for whatever depending on what we have in terms of investigation and see what they reveal.
Ajit, do you agree with Subhash or Neeraj, or you have your own?
Ajit, you are mute. Ajit, you are mute.
Our I see the commonest, the bacteria which is definitely is Acinetobacter and Klebsiella. So maybe I would like to go for a meropenem with polymyxin in this situation. Maybe just start empirically to cover, at least till the reports are there, till further reports are there, just an initial antibiotic, I'll start both to cover, Acinetobacter as well as Klebsiella.
So I think the lesson is that there is no one guideline for VAP. It depends upon the epidemiology of your unit. Like in units like ours and in Gangaram, Acinetobacter is not so common, probably I can afford to use Taz-IV Aztreonam because we don't have Acinetobacter. So we can safely not use, antibiotics against Acinetobacter. But in units where Acinetobacter is still also a significant pathogen, they probably have to cover both Acinetobacter and CRE. So their antibiotic strategies are a little different. So ultimately, the answer really is that there is no one answer for this. It depends on the epidemiology of your unit. The other question I wanted to ask is that do you all do a pneumonia PCR panel in every patient with VAP, or if you don't do it, it's of course an expensive test. So when do you consider doing it in a patient with a VAP? Routinely or only selected patients?
Sometimes it leads to overuse of antibiotic.
So what is the policy? When do you use it?
Yeah, so somebody who is really sick with a VAP, who is might have gone into shock with bacteremia, very high FiO2 requirements and PEEP, then probably, but not as a positive predictive value, because PCR in a VAP is going to show many organisms, but it will be a very good negative predictive value in the sense that if my PCR is negative for Acinetobacter, that means I don't need to cover for Acinetobacter. So that's how I look at it, as a negative predictive value.
You would reserve it for the sickest patients. What about Neeraj and Ajit?
Somebody who just got a VAP and not that sick, then I would wait for culture, start empirical antibiotics, and await the culture and gram stain culture and all. Only one thing, Ashit, I would like to mention about this polymyxins for pneumonias. As we read the literature, they have completely discouraging the use of polymyxin for lung infections. And unfortunately, we don't have any head-to-head studies of polymyxins with sulbactams and minocyclines. But they, over the last few years, I've been using less and less polymyxins for lung infections.
I think more and more in our country, people are using nebulized polymyxin. I understand literature against nebulized antibiotics also is negative, but I think there's so many problems with the dose used, the method of administration. I think that's a subject debate whether nebulized polymyxin administered at a higher dose, administered through a vibrating mesh makes a difference.
Nebulized is out. Nebulized is not recommended at all. Even
I understand that, but they don't have the problem with that we have. So I think we can't really. We need to get our studies. There are studies from our country for nebulized antibiotics which seem to suggest that if you use a high enough dose, see, if you look at the other studies, the delivery devices were different, the doses were different. There's so many. It's a controversial topic. I really don't think the last word has been said about nebulized antibiotics. I think we can have that for another debate about it. But I understand the Western literature is against both IV and nebulized polymyxins for VAP. But I think in our country with our resistance, I don't know whether we can afford not to use it.
Apart from Acinetobacter, there have been two studies, one from Parikshit Prayag and another from Rajagopalan. Both are observational studies. They looked at comparing polymyxins with ceftazidime with or without Aztreonam in their ICUs, and they have found that ceftazidime and Aztreonam, these are for Enterobacteriaceae, was better than polymyxins. But for Acinetobacter is the only problem.
Yes,
we don't have any other choice.
Completely, I agree. Only Acinetobacter, not others, not for CRE, no question.
Exactly.
What about Neeraj? Do you all use the PCR pneumonia panel at all?
No. For VAP, we are almost hardly ever using VAP.
Quite expensive.
Like PCR panel for VAP, because we know what we're going to get. And unfortunately, apart from some of the genotype mechanisms, it gives me nothing. So we know.
So we do for occasionally use for certain immunocompromised patients, post-transplant patients, bone marrow transplant patients, when they come into required pneumonia as well as on ventilator, as well as, in ventilator-associated pneumonia, we do use it. Not very commonly, not for other
all
patients.
of us agree that we're going to use it very, very selectively. It's not
very selectively, yes, sir.
So again, I know, but I'm just giving a scenario that this is what the pneumonia panel report shows. Nowadays, the pneumonia panel gives a bin value, which is something equal to the, like the colony count. So 10⁶ Acinetobacter, 10⁴ Klebsiella, CT, XM, and Oxa. And similarly, blood culture PCR panel shows Acinetobacter, but no resistance genes. So, and the patient is on polymyxin minocycline. I mean, this is just theoretical, but what would you do in the situation with these two reports? Because the whole, we are trying to focus on how to interpret this,
Yeah, I would add sulbactam to this, and no resistance genes for Acinetobacter doesn't have, because these at least the BCID panel doesn't include all the resistant genes for SNE2.
I think that's a very important point, Subhash has made that, for the students, that merely because it says no resistance gene doesn't mean it's a sensitive Acetobacter. Because with Acetobacter, the mechanism of resistance are not necessarily enzymatic. It's porin, efflux. The OXA is different from the OXA of CRE. So the fact that no resistant genes does not mean it is not a resistant bacteria. It still is going to be probably pan resistant. So that's an important lesson for the students, that don't get fooled by the no resistance genes. This still is going to be a very resistant Acetobacter. That's the point he made. So you would probably think of adding sulbactam to the.
Yeah.
Anybody else has any other views on this? So you would ignore the Klebsiella, or you would treat this Klebsiella?
No, blood culture has grown SNE2. Huh?
So you would ignore. So that's the other point, that if there is a difference between the blood culture and the sputum non-sterile side, you probably believe the blood culture. You don't believe the non-sterile side. You go by what the blood culture shows. You don't have to treat every possible organism that has grown. That's I think again a lesson for the students. Neeraj, any other point you want to make?
I think I will not add anything. Polymyxin and minocycline, they are working very fine for us since last
Would
year.
you add sulbactam, or you wouldn't add sulbactam?
No, I won't add anything. This is
So there are a lot of
polymyxin, minocycline is good enough for us.
What about you, Ajit? You also.
No, I may not add anything immediately, but I'll have a next plan I will always make actually, So maybe sulbactam, I'll just keep it in mind. I won't be adding anything immediately.
So there's some important lessons have been made, that you ignore the one, of course, because it's a lower bin value. Two, because the blood culture is not going to ignore the Klebsiella. Two, just because remember the BCID panel is much better for the CREs. It's probably not so great for the non-lactose fermenters, because the mechanism resistance in the non-lactose fermenters is different from the enzymatic. So it may not be that great. It's more important really for the CREs. Sometimes if in Pseudomonas you get an NDM, etc., it shows that some antibiotics can't be used. But otherwise, again, the BCID panel is really more useful for the non-lactose fermenters. Finally, do we have time, Jacob, or do we?
Sir, you have one more case means we can discuss, sir. I think we were 143 delegates waiting for you. Probably we can extend for 5 more minutes, sir.
Only one final point. I just want a final case, same scenario. The gram stain of the sputum shows gram-negative bacilli. The blood culture shows gram-negative bacilli. But both the pneumonia panel and the BCID panel show no organisms. How would you interpret this? Blood culture has gone gram-negative. The sputum has grown gram-negative, but the BCID panel and the pneumonia panel has shown no organism. How would you interpret this?
So your PPD is not visible, sir. Yes.
No, but anyway, that's okay. I asked a question. That's why my PPD.
I know. Okay.
I asked a question that you have a scenario where the blood culture has grown gram-negative and the sputum has shown gram-negative bacilli, but the BCID panel, no organisms are detected. And even on the pneumonia panel, no organism detected. So how do you interpret this report? Do you blame the lab saying they're not right? Is there something else?
So the blood culture is positive. Definitely, it is. You have to take it very seriously.
Why is the BCID panel negative? Why is it
we cannot ignore that. But the PCID, the panel, the issue with the panel is that it is a rapid diagnostic testing. It depends on the panel which is there, which is incorporated in the particular test. If the particular organism is not incorporated in the panel, then it will be negative.
So which bugs would you think about? That's what I meant, which are not in the panel, because like you said, there's a library of.
Sir, just now I was listening to Dr. Soumya. So basically, I think the biofire panel is around 19 bacteria, 5 fungi, and some 3 genes or something. 3 resistant genes are detected. If those bacteria, if the particular bacteria which is growing now, the gram-negative bacteria, it is not there in the panel, it won't detect. I will like to explain this in a very simple manner, sir. There is a study in IJCCM which was published around 3-4 years ago. It is about meningitis. It's a Trivandrum study, Kerala study, meningitis. I think around 30-35 patients were there, and the meningitis, the conventional culture was compared with the biofire. So one good thing about the happened that all the cases where the biofire detected some organism, in all cases where the biofire detected the organisms, the same organism was detected by the conventional culture. That means biofire has got a very excellent specificity. Whatever biofire is telling, it is all the cultures, the conventional culture of this one. And another thing was that in biofire could detect more bacteria, because many cultures are negative. Biofire could detect more organisms than the conventional culture. But there is a loophole in the case. At least three patients, if I am not mistaken, the 3 patients grew organisms which are not detected by biofire. But if the culture was positive. What I mean to say that culture positivity can be there, but the biofire, the panel can be negative. This can happen. My understanding is only if the particular panel of the bacteria is not incorporated in the panel. The people who are sending the test should be aware of the panel what they are sending. If the panel does not represent the particular organism you are looking for, then it can be negative in the panel. Any other inputs are welcome.
I mean, Stenotrophomonas is the commonest one, which is not picked up in my ICU when you talk about both BCID.
Stenotrophomonas is on the BCID panel, Neeraj.
Sorry?
The point is right, but Stenotrophomonas is on the BCID panel.
Burkholderia and
Burkholderia, I think, was the answer.
Burkholderia is also in
ultimately what Ajit said is right, that you have to think of organisms which is not on the panel. Yeah. You don't say that the lab is wrong. Why have they got BCID wrong? It's basically, it is not in the library or not in the panel of BCID. So basically, like you said, either Stenotrophomonas, which is not on the respiratory panel, but not present on both respiratory and blood is Burkholderia, especially COPD, steroids and all that. Burkholderia. So these
Morixella as well. Morixella and COPD becomes really important. It's not there.
Yes, exactly. So these are the things you need to think about when the blood culture is or some other, but the molecular BCID panel is negative. You understand that it's not a lab error. It is something which is not on the library of the. That was the important point that I wanted to make.
No, actually, most of the organisms which are not there in the BCID panel, these Elizabeth Kinglias and all those Burkholderias, there are three very common all of them, most of them are sensitive to minocycline. Most of them are intrinsically resistant to colistin, and most of them are waterborne organisms.
Exactly. You need to have
these are the three things which are very peculiar to this BCID negative, gram-negative organisms, which we find in chronic dialysis patients and all.
So that's I think a lot of important points made about this, especially like somebody's on colistin or somebody is on already Thiazide, etc. Whatever. Thiazide sometimes works against these organisms, but you have a situation where gram-negative is there in the blood but not in the BCID panel. Think about this unusual organism, Elizabethia, Chrysobacterium, Burkholderia, Stenotrophomonas. And like Subhash said, I think drugs like minocycline, sometimes quinolones might work rather than colistin, etc. So I think we made a few important points. Are there any questions? I think.
Yes, sir. Yes, sir. Thank you. I think thank you so much, Dr. Ashit and the panelists. This discussion will never end, but lot of important takeaway messages has been communicated very clearly. And Dr. Subhash sir, I know you have to leave, but I think thank you so much for joining us. If you stay there, it will be very helpful for the questions also. Dr. Bharat and Dr. Soumya, hope you are there because questions can carry towards your talks also. The first question. This is regarding one of the empiric questions. Any rationale combining colistin and aztreonam in sick ICU patients? Dr. Soumya, your take. You go to Dr. Soumya.
Yeah. So I wouldn't actually combine only aztreonam. So it depends on what you're treating. So if it's a VAP situation, colistin plus maybe ceftazidime avibactam aztreonam, because aztreonam, as you said, that can be co-carriage of it, just acts against NDM, but still it's not good against ESBL. So you would need an additional drug like ceftazidime avibactam aztreonam combination, as in it's an aztreonam avibactam combination that I'm looking at. I wouldn't use aztreonam separately.
Okay. Now, second question is regarding the new antibiotic. Dr. Ashit has mentioned about experience about cefepime and enmetazobactam. I think we have covered enough. I have only one question to the panelists. Just want to find out about this particular cefepime and enmetazobactam. What is the rationale using in AMC producers?
I think if it's pure AMC, it will work, but we don't test for AMC in our panel. That's the trouble. So it will work for AMC plus ESBL.
Absolutely.
Got it, sir. Dr. Bharat, any comments?
No, I was saying MC, better we go for the carbapenem. I mean,
ESBL. For MC, that's okay. I think the main problem is that it is a pure MC or MC plus ESBL, it will probably work, but it won't work for, other things like etc. So essentially, it's like everybody talking, it's probably a little lower than a meropenem or maybe equivalent. We don't have studies to say it's equivalent, but probably somewhere between BLI and a carbapenem. That's how it would be.
Got it, sir. The next question is that
I had one slide which I had shown where when it's ESBL and MC, then how do we decide whether it's carbapenem or BLI? So as sir said, if patient is not really sick not requiring fluids, it's not an competent immunosuppressed patient, and the disease is not related to the UTI somewhere else, then we can consider carbapenem. But of course, or if the disease is with the UTI, then we can consider the BLBL as. If it's a sick patient, immunocompromised, and the disease is not with the UTI, then we might consider carbapenem. So, but whenever we use BLBL in case of the AMC and ESBL, we need to be very cautious.
Got it. So, got it. Thank you. So, next question is that if the patient is put on ceftazidime avibactam in deranged kidney function test, should we add aztreonam or we modify the dose of both antibiotics together? I think Dr. Subhash has made it very clear that, yes, even the drug modification is there. We need to be careful about the creatinine, and repeating a creatinine and modifying is something which is very, very important. And in CRRT patients, of course, you all know the dose modification. I think we'll go to the next question.
I have a small comment on that. Dr. Soumya may be able to clarify, I believe. No, because I came to know some recent literature that, the patients with renal impairment with ceftazidime avibactam, when you make the dose adjustment, the mortality was found to be on the higher side. So if you make the dose adjustment, you mean to say you reduce the dose, the mortality is supposed to be a little bit on the higher side. Is it how the data is evolving? Are you aware of that?
Yeah, so we use ceftazidime avibactam and aztreonam together. Typically, in a septic patient with septic shock, the first 24 hours we do not dose adjust, we give the full dose. And then we dose adjust depending upon the creatinine clearance. And when I dose adjust, we reduce the dose of ceftazidime avibactam along with aztreonam. For example, if your creatinine clearance is less than 30, say, so it would be 1.125 8th hourly with 1 gram of aztreonam. So both.
No, when the dose is adjusted, the mortality is said to be more. Is it?
Yes,
some observation was there. So that means you give a lower dose, the mortality was more. Is it a true thing, which is how it is evolving?
No, I think her point is that first day don't adjust the dose.
Yeah, I wouldn't. So if that holds good for any of the antibiotics. So there's an augmented renal clearance. So in a septic patient, don't adjust initially, and then you dose adjust after your 24 hours.
Maybe most important thing is the ratio. Is for every 2.25 gram of ceftazidime avibactam, you have to give 2 gram of aztreonam. People are just reducing the dose of aztreonam. And the ratio needs to be maintained, and both need to be infused simultaneously. Unless you do this, you will never get the right kind of
combinations. No.
Yeah.
I think that you are on the side of higher dosing at least. Don't worry too much about it.
And usually aztreonam and Tazavi are not a nephrotoxic drug. So if the just creatinine going up, I wouldn't adjust the dose. And unless and until we have the acidosis and urine output dropping. This is what we learned.
Yeah, Dr. Soumya, there is a basic question, maybe some sort of a basic we can answer. Why colistin given intermediate sensitivity these days in culture report? Just quickly can answer the question, Dr. Soumya.
That's because of the discrepancy between the CLSI and the UCAST guidelines. So based on the CLSI, we go with less than 0.5 itself, we take it as sensitive. So there's no intermediate category there. So it depends on the MIs.
Yes.
Between bodies, that is the difference.
Yeah, thank you. Fosfomycin is not recommended by IDSA for pyelonephritis. Are we justified in using it for pyelonephritis? This is first case of Dr. Ashit.
Should I take the question?
Of course.
Yeah. So fosfomycin, most of the literature, the best because they have very good other agents that are available. So they have meropin, and it's mostly KPCs that they look at. So our resistance profiling is entirely different, and our antibiotic choices here are limited because of the availability of the drugs also. I wouldn't entirely disregard IV fosfomycin, but I wouldn't go with a monotherapy in a severely septic patient. So in the first case that was discussed, my opinion is I would start colistin because I would rather have a living patient with a dead kidney rather than think about antibiotics later on. So I would stabilize him, start with IV colistin, add fosfomycin, because if there are any cultures prior, I would go based on that. Because if it was E. coli, probably you would have selected out the same E. coli and I would add a fosfomycin. If it was a CLEP, then probably colistin with ceftazidime avibactam that I would add. And phospho also gives your enterococci cover. So if it's in my ICU, if it's a septic patient with a urosepsis that I'm looking at, colistin plus fosfomycin would be my drug of choice till I stabilize. 24 hours later, when I get the ID, if it's E. coli, I would still continue fosfomycin. If it's CLEP, I would probably stop colistin and phospho and switch over to zavicefta. This is what I would.
Great. Sir, this is regarding communicated pneumonia. Patients with severe CAP in shock and MODS, probably the empiric coverage, which is better, linezolid or teicoplanin? Bharat?
Patient with shock and I
CAP,
missed the question.
community acquired pneumonia in severe shock and MODS. Probably the empiric coverage or MRSA coverage that the delegate wants to ask. Which is better, linezolid or teicoplanin? Lung infection.
Lung infection, initially we would go with the teicoplanin. The reason being is, I mean, linezolid is not bad because that's a bacteriostatic and that affects
MRSA pneumonia or any pneumonia? CAP.
So they are not mentioned. No, I think probably the empiric coverage or MRSA, so we can talk, sir. They are not mentioned.
I don't think there's any point of using either linezolid or teicoplanin. I mean,
so initially I was going to give the answer that way, but he said MRSA.
MRSA pneumonia, because otherwise it's a question for normal pneumonia and shock is pneumococcus.
Yeah, we put as MRSA pneumonia.
Okay, MRSA pneumonia, then Bharat, yours, all yours.
No, my answers continue to the same thing. I mean, my answer wouldn't change. I mean, we learned it from you only, so it would be the same.
Ashish sir, this is final in this panel. That's what we all feel.
No,
Sir, the next question is that by what method synergy testing is more reliable? Dilution.
I think the standard usually is broad dilution, but now they say that e-test is almost as good as the broad dilution. Even this MRSA is saying the same thing. So I mean, Dr. Soumya can probably throw the same, so more light on it. But we go by what ICMR is saying. So e-test is equivalent to whatever they have been doing.
You're talking about synergy, no? You're talking about synergy testing, no?
Yes.
Yes, sir.
On the agar place, yeah.
Synergy.
So Soumya, you might have to talk
Problem is that broth microdilation is not available in all of the setups. So if it is available, broth microdilation is more accurate and would rather go with it. But if that is not there, then we go with e-test. So what we have here is only e-test. We don't have
e-test, yeah.
Does tigecycline achieve UTI?
No.
It's not a very good agent at all. If you don't have any other option, then probably it has a good tissue penetration. Probably if it's a pyelonephritis and you do not have other options that you can use, desperate situations would add tigecycline.
Next question, I think only Ashad sir can answer it. Sir, mainly, which criteria should be followed to upgrade antibiotics in septic shock patients?
Which criteria upgrade? It's not getting better, you obviously upgrade. Then once you get your BCID panel...
He's asking for which criteria. Which criteria should be followed? I don't think anything.
Clinical response, no? And how sick the patient is. The sicker is, the faster you upgrade. Of course, most important to make sure there's no source control issue. But otherwise, the sicker is, the faster you need to upgrade. Obviously, you can't, because you can't, like Soumya said, you're going to use colistin phosphomycin upfront in a sick patient. So I think in a sick patient, you have to really can't afford to be wrong. You can then come down once you get your cultures back. But initially, you have to be, the sicker is, the higher the broader you cover. So, but that's why molecular diagnostics, etc., will help us fine tune faster. So, that's what we need.
Yes, sir. EDTA containing antibiotics experience in ICU use.
We don't have it in our hospital at all, so I can't talk.
Soumya, any comments on that?
So we don't have data. It is DCGI approved, but we do not have data. So I would refrain using, but I have used for a couple of patients when I do not have colistin. I mean, if it's a CCFRE, then Eloris was actually a bridge.
Combination or it's single?
Combination, as in I did not have any options for one patient whom I used Eloris until cefepime-zidibactam was available. So we had to procure it and give. So that's a better drug that we are looking at, cefepime-zidibactam, in terms of coverage and sensitivities. So if it's available, I think it would circumvent all our problems. Eloris, I have not personally used much. I've used as a monotherapy because all the other agents were resistant for this patient.
I think we completed almost. Sorry,
we don't have it in a hospital too as well. We don't use it, but what I know of is basically in vitro and in vivo. The concentration of EDTA, what is required and has been tested in the vitro, is quite high. If we give the same quantity in vivo, it's quite a toxic drug and is not available commercially in that kind of amount. What is actually required to achieve the MIC in those certain bacteria. So this is what we know of, but haven't used it. Have no often experience with this.
Important point, because like you said, the concentration of the disc is very high, so you can't translate that to
too high. It's very toxic. Yeah. So actually, what we achieve commercially is not that high concentration EDTA. So it's not worth.
As combination therapy, whatever we have used in certain patients, I'll say almost 50% of these patients, it does achieve microbiological clearance. But when you look at the mortality or the endpoints, I mean, it's really impossible to find whether these antibiotics work. You need a very complicated kind of a study to find whether these concentrations, as Bharat is rightly pointing out, which is commercially available with all these antibiotics, does it work or not? Very simple. So, but never as a monotherapy.
Yes.
Let's be very clear about it. Never ever as a monotherapy.
I think we have covered almost everything. I think I'm surprised to.
I think Jacob, one final question, maybe somebody.
Yes, sir.
Yeah.
Ceftazidime is better, or ceftazidime avibactam plus astronam better, or avibactam plus astronam? Now that I think.
Okay. What's the guidance here? Yeah. Sorry. Yeah. Oh, last question. Yeah.
Somebody want to take that? Which is better?
What's the question?
Is ceftazidime avibactam plus aztreonam better, or the much awaited drug aztreonam avibactam is better?
It's actually the same thing that we are looking at.
Yeah.
Same thing. In vitro, we are testing the ceftazidime avibactam plus aztreonam synergy. In essence, it's the aztreonam avibactam combination that we are actually testing and using. So if aztreonam avibactam is available as a single molecule, I would definitely prefer. But there are other smaller companies that are actually producing avibactam separately, and they ask you to combine avibactam and aztreonam. Personally, for me, it has not worked. So I do not use aztreonam and avibactam separate molecules as of now. Would wait for a proper molecule before using. I would still consider only ceftazidime avibactam aztreonam. Actually, it's the avibactam aztreonam.
I discussed this with Balaji. I mean, his view that he said when that, like you said, Pfizer is going to come up with avibactam and aztreonam. He said that for an NDM, he would prefer. See, ceftazidime actually is a waste because we are only using the avibactam bit. But he's still saying ceftazidime, avibactam, aztreonam is probably safer than avibactam, aztreonam. So he's saying for pure oxa, probably he would stick to ceftazidime, avibactam, aztreonam. But if it's an NDM, then he would prefer avibactam. That's his view on the safety concerns. That maybe
theoretically, sir, this is aztreonam and avibactam, because we give avibactam just to protect the aztreonam, the hydrolysis effect.
The dose of avibactam in this molecule is much higher. The dosing of ceftazidime of avibactam, the ratio is different. His view was that from a safety point of view, for an NDM, you use aztreonam, avibactam. For pure oxa, not aztreonam. For pure oxa, you don't need aztreonam.
If it is only an oxa, we still do not need the aztreonam.
You don't need aztreonam at all. That's what he meant. For pure oxa, you don't use. That's what
NDM, it's going to work.
So pure oxa, ceftazidime, avibactam, NDM use aztreonam, avibactam. That's what he's saying.
Okay, that's the right answer, sir. One more question is there. I think, is there any antibiotic combination better than polymyxin combination for crab pneumonia, Acinetobacter?
Yeah, discussed. Poly-B is actually, it has a poor lung penetration, but polymyxins are invariably 100% sensitive for Acinetobacter, at least in our ICU. So upfront, I'll have to start a polymyxin-based combination therapy for a severe crab VAP. And then I would probably do away with the polymyxin if it is going to be minocycline sensitive. Probably look at minocycline and sulbactam combination for a severe Acinetobacter pneumonia. But the problem in our ICUs is minocycline sensitivity is only 35 to 40%. So upfront, I'm not very confident using minocycline at all, to be honest. So tigecycline is slightly better. So we start poly-B with tigecycline combinations and then switch over to either tigecycline or minocycline along with sulbactam. This is what we do.
One last question. I think antibiotic dosing in acute kidney injury is better urine output based modification or creatinine based modification?
I think there's no answer to this theoretically.
So the answer is, if you are having creatinine, which is high without any urine output versus you have some urine output, you have to compensate slightly higher for the clearance. So anuric AKI, the clearance is slightly lower as compared to non-oliguric or non-anuric AKI. So in non-anuric AKI, you slightly err on the higher side of the antimicrobial rather than what you typically go for that kind of creatinine clearance. This is very simply how we are doing it.
Thank you, Dr. Neeraj. Dr. Ajit has answered the question on lung penetration of linezolid. Thank you, Ajit, for answering that. I think we have almost wind up everything. Now, I am only request one thing, because 100 delegates are still, waiting 1.5 hours post discussion. I think that's a testimony to the speakers, Ashit sir as a moderator, and all the panelists. Thank you so much. I have one thing to ask all of you. Dr. Soumya had a case scenario, which probably I think if we can quickly take it up, it may be beneficial to the delegates who are waiting till 8:30. Are you guys okay with that or not? Dr. Mona, I think Mona is the person to give permission.
Well, I'm okay with it because delegates are waiting. But I think rest everybody has a choice to wait. I would like to listen to her. So
the panelists and the faculty and the speakers, definitely you can have a choice. Dr. Soumya, please, we will just go ahead and quickly discuss that case, what you have shown.
Sure. So this was just for a teaching. I am not. I just wanted to re-emphasize what I spoke about.
Yes.
So this was a 40-year-old gentleman who was an alcoholic, and he presented with epigastric pain. As you can decipher from the history, it looks like a pancreatitis. So it was an acute pancreatitis, was hospitalized outside and had received imipenem for 10 days. And on day 13, he came to us with worsening illness, fever, hypotension, and these are the bloods that were done in the other hospital. Counts were slightly high, platelets fairly normal. The culture was negative. So actually, he received an empiric imipenem for 10 days. And these were the labs in our hospital: leukocytosis, inotropic supports, platelet was 1.25, creatinine was slightly high. So we sent in blood cultures, and beta D glucan shows 150. Cultures, urine cultures are also awaited. So as you can see that this is not a urosepsis, but I just wanted to emphasize that we just sent appropriate cultures that would be better. And here, most likely it's going to be an acute pancreatitis with probably an intra-abdominal infection that he is having, and has received empiric imipenem with current shock situation, septic shock. So what would your empiric choice be, and what would your next line of action be? If they want any interaction, I'm okay to it. Otherwise, I'll proceed with the case.
You can proceed, Dr. Soumya. You can proceed because it's.
So yeah. So the lab calls saying there are GNBs growing on your blood culture. So immediately the reflex should be that this patient has been carbapenem exposed. So it is wise to order a blood culture ID, MALD, with a carba or a direct BCID. So in this situation, we sent in a blood culture ID panel, and antibiotics were, upfront high end. What we saw was it was an ESBL, NDM, and an OXA producing CLEB. So, antibiotic wise, ceftazidime, avibactam with aztreonam would be a wise choice for this patient. So what unexpectedly or expectedly happened was this: the BDG was intermediate, as you saw that it was around 150 only, but the BCID also picked up Candida auris. So this is one of the few advantages of ordering a BCID in these situations where you can upfront. Your BDG was intermediate, but the blood culture did not flag Candida as yet, but your BCID picked up a Candida auris. So it was easier for us to directly start. Most of the ICUs, the patients get started with an echinocandin. But this would actually reinforce that we needed to continue the echinocandin despite the BDG being intermediate. So finally, this patient also grew Candida auris in blood, and he had to get a pigtail, drain the fluid, and that also grew Candida auris, which had similar DSTs to the blood culture. So just the take-home points from this case was that BCID is helpful not only for your gram negatives, but also to identify fungus in these situations. Yeah, that's all.
Thank you, Soumya. I think this is very useful. Nice way to end.
Thank you.
There's no more questions, I think. Yeah.
Yeah. No more questions, no more.
Yeah.
No,
so
but
I
the
think
beta D glucan was high, isn't it? The beta D glucan was high. I know it can be false positive.
Yeah.
It was
definitely high. That really makes you suspect. I know it can be false positive, yes.
But I just wanted to say that the yeast flagged later on. So day 3, only the culture flagged yeast. But this gram negative was faster to grow. Based on that, if we had actually stopped the antifungus, then we would have missed the bus.
Thank you. Thanks.
Thank you so much.
Thank you so much. So, Dr. Mona, will wind up. I think it's almost 8:30, 8:40. So, let me put it on record. My sincere thanks to the speakers, Dr. Soumya, Sridharan, and coming back again, and Dr. Bharat for definitely putting it with all the patents, resistance, and then covering it extensively with the limited time. And Ashit sir, as always, he has a passion of infectious disease and antibiotic choices. For moderating, and an excellent panel comprising of superstar sir, Dr. Ajit and Dr. Neeraj. I think the practical questions and the challenges have been really addressed. And many thanks to Dr. Mona Lisa. I think her choice of topic in webinars have been really making a difference in the crowd. Waiting till 8:30. That's something which is impressive. And thank you, Chirag from ISCCM, and thank you ICCM Central Committee and Mumbai office, and Dr. Anvir Tyagi for giving us this opportunity. Wait till next month.
Compliments in the chat section for all the speakers and panelists. So thank you all for joining us. We'll see you next Friday, same time, same place, I guess.
Thank you, Dr. Mona. Thank you, Jacob.
Bye.
Bye. Thank you so much, sir, for a really nice having a panel.
Yeah.
Bye, Bharat. Bye, Dr. Soumya.
Thank you. Bye, everyone.
Bye.
Good night.
Great, guys.